to Greendale Physical Therapy, Neurobalance and Vestibular Center. I just want to give people just a quick orientation of the Worcester facilities here. We used to be at this facility for our orthopedic clinic. We outgrew the facility and we moved our orthopedic clinic across the street to a 5,000 square foot space there. And we kept this space for our Neurological Balance and Vestibular Center, which is sort of the first of its kind in central Massachusetts. And we're looking to grow it, and it's great that we have doctors that are helping us do the lecture series here and stuff. So I want to thank Dr. Deeb for coming and doing this for us and for the community. So I just want to give a quick introduction, bio. Wissam Deeb graduated from medical school at the University of Balamand, Lebanon in 2010. He completed his residency in neurology and then movement disorders fellowship. He has been in independent practice since 2017. He currently works as a physician and assistant professor of neurology at UMass Memorial and UMass Chan Medical School. His clinical interest focuses on Parkinson's disease, deep brain stimulation, and Tourette syndrome. In addition, he spends a large portion of his time teaching medical students as the neurology clerkship director. Introduce you, Dr. Deeb.
Thank you very much. Thank you, everybody. I'm going to discuss today Parkinson's disease progression, and then also some of those what we call advanced therapies. You can interrupt me any moment if you want. You don't have to hold them to the end. And then if this is something that I'm going to discuss in a bit, I will tell you we'll be discussing it later, okay? And then I sometimes have a tendency to drop my voice and then go quiet. So if you're not hearing me, especially in the back, just say like go up and I will increase my volume back again. All right, so in terms of disclosures, I don't have major ones, but I am on the board of one of the Parkinson's organizations, the Davis-Finney Foundation. I'm not discussing anything related to them, but just wanted you to be aware that this might influence some of the things. All right, so those are the topics or the outline of what we're discussing today. We're going to start initially by reviewing Parkinson's disease, reviewing the progression. We're going to discuss some of those advanced therapies, so that's DBS and infusion therapies. And then after this, we're going to take some random cases, discuss random scenarios, and then also some time for you to ask questions extra at the end also if you have. So I'm going to start initially by showing you a video. This video is from the internet, okay? I just want you to tell me what you think this video is showcasing. I'm not sure if you could hear. I could hear a little bit, but I'm not sure if you could hear it. No, but the person is speaking. They're not speaking in English, but they're speaking. They're speaking full sentences that make sense.
Are we supposed to hear that?
No, you don't have to hear it. Just I'm telling you that he was speaking full sentences that make sense, and then he was moving in his sleep. Anybody have any idea what we call that? And
hallucinations?
Because the person is asleep.
Mm-hmm.
Acting out dreams.
Acting out dreams, yeah. So this person is acting out their dreams, and that's some of the very early symptoms of Parkinson's disease. It's not specific though, it can happen for many other reasons, but it can happen up to 10 or even 20 years before a person starts having Parkinson's disease, where the person, not that much, but around 10 years before a person has Parkinson's disease, before they have any other symptoms. They this is the thing that people would notice, that they're acting out their dreams at night, they're punching, screaming, kicking. But usually they would, if you wake them up, they will tell you, oh yeah, I was having a dream. And they can tell you it's usually a violent dream. They're chasing somebody, somebody's chasing them, they're defending, they're like in the Superman League or something like that. It's usually very action oriented. Again, it's not specific, so if you have those types of symptoms doesn't mean you're having Parkinson's disease. It's just, it can be part of it. It can happen many years before those symptoms start. And the reason I'm showing you this is that Parkinson's disease is complicated. It's not one thing or two things. It's not like slowness, stiffness, and that's it. It affects multiple things in a person's body, brain, and even skin, everything effectively. And the main problem in Parkinson's disease is that there is this decrease in a substance in the brain called dopamine. And that's the main feature, the main problem in Parkinson's, but there are other things that change. And then if you can see this like schematic or this picture, you can see like the multiple things that are there. They divide the symptoms into two components. There's something called motor symptoms. Those are on the upper part. And that will be like stiffness, slowness, tremors. That's what we think about when we think of Parkinson's disease usually. But on the lower side, there are other symptoms. They're called non-motor symptoms. So this could be the symptom that we just saw, the acting out the dreams. It could be loss of sense of smell. It could be difficulty with urination. It could be pain. It could be a sleep disorder. It could be many other things, cognitive disorders, so changes in thinking and memory. So all of those are part of Parkinson's disease. And then when a person is being managed for that, you're trying to help them with all of those and not only their stiffness and their slowness. But to diagnose Parkinson's disease, you need to have the motor symptoms. You cannot diagnose it simply based on the urine problems and the sleep problems and other symptoms. You need to have those symptoms of slowness, and we're going to see what they look like. You need to have stiffness. You need to have, you don't need to have tremor, but some people have tremor. But the main feature really is the slowness on the exam. So it's going to see a series of videos, and these are all what we call motor features of Parkinson's disease. I'm just going to give you the name, what we call them, but this is what they can look like for different people. So here you see this person is walking, stooped, small steps, not lifting the feet up too much. And then when they move, they take very, very small steps they sometimes go fast. This person has back pain too. And then they're going to keep walking. And then this is a characteristic gait that you would see, or walking that you would see in a person with Parkinson's disease. Also, you can see that sometimes the sitting can be a bit affected. This is another thing here. What they're doing is a trick to help with something called freezing of gait. This person has difficulty starting the movement. You can think of the leg as almost stuck in mud, and you're trying to lift it, it doesn't want to do it. They want to move, but they cannot move. And then one of the tricks that physical therapy can teach a patient is to maybe have something they can step over, and that sometimes can help with unfreezing. But you can see it's difficult. And the person, if they're not supported here, they might fall. This is what I was saying about slowness. So this is when a person is tapping their foot or tapping with their fingers or turning their hands. And then you're going to see that the movements could be smoother, could be more controlled. Whereas here you see the movements are not controlled. They're irregular. They can tend to be a little bit slower or small. And then these are things you need to see on the exam to make the diagnosis. Here the person is trying to tap, and you can see they're barely lifting their foot rather than tapping more vigorously. And this is a person who has tremor. This is the typical tremor in Parkinson's. You can see their hand is twitching without them moving their hand. So their hand is resting and they're having the twitching in their hand. The other thing you can see in this person is that they have what we call a poker face, a very flat face that doesn't betray emotions very much. And that's also another feature you would see. None of those by themselves make a diagnosis of Parkinson's disease, but when you combine them together, then that's possible for diagnosis. Again, we're not doing a course on what is Parkinson's disease, but just to give a quick intro to that. Now, how do we treat these symptoms, these motor symptoms, the ones that you saw, the stiffness, the slowness, the walking problems? We treat them with the medicine that's been on the market since 1971. And that's carbidopa/levodopa. It's a mouthful. And this is the best medication we have. And the reason it's a good medication is that it simply replaces dopamine. It's a substance that you can take, and then we replace the dopamine that's missing. Similar to when a person is diabetic, they need insulin. You give them the insulin, their diabetes gets better. It's the same approach here. There's dopamine problems, we don't have enough. We're going to give you dopamine, and that will replace it. And the amount that a person takes is very dependent on that person. Some people need 1 pill 3 times a day. Some other persons might need 2 pills 10 times or 12 times a day. So there's no like one good number that works for everybody. Now they come in different brand names. The oldest one is Cinemet, and that's the easy to remember one. So many people hate to say carbidopa, levodopa, so they say Cinemet. The other brand names are Retari, and the newest kid on the block is Crexont. They're all carbidopa, levodopa, so they're all the same substances at the end, but they're packaged differently and absorbed differently. They have different properties and how they're released in the body. But at the end, they're all carbidopa, levodopa. Now, this is the medication treatment, the mainstay medication treatment, but when we treat Parkinson's, we don't treat just the medication. As we discussed, the Parkinson's is complicated. There's so many things going on. Not all of them are going to respond to the carbidopa, levodopa treatment. So you can think about it, we need what we call interdisciplinary or multidisciplinary care, which means multiple people are going to help a person with Parkinson's disease. And one way to think about it is think about it as the person with Parkinson's is the sun, and we're all rotating around the sun. That can include a care partner. That can include a physical therapist, that can include the neurologist, that can include the mental health counselor, that can include a nutritionist. Many people can come in and help a person with Parkinson's disease. Some are like distant planets, they come and visit once in a while, but others are more frequent parts of the team. So that's one way to think about the care for Parkinson's. Complicated, it's many things together. Now we're going to... But as Parkinson's, so when a person gets diagnosed early in their disease, we give them the carbidopa, levodopa. They go into a period called the honeymoon period, which means that the medicine works so well. They take the medicine, it works very, very well, and then they can forget about it. They don't feel the difference. It's a good time. There's no complications. Everything is great. You get that significant improvement, and that's another feature to make us more confident that this is what we're dealing with. But as the disease progresses, and these numbers don't code them, those like 0 to 4, that's not. This is just random numbers, okay? So it's not like at the 4th year there's a change. But as the disease progresses, you're going to start developing complications as part of the disease progression and the medications. So the medications will start not working in the middle of the dose, will not work as much, their duration of effect will shrink, or you start having side effects like there's too much movement. I'm not sure if you've seen Michael J. Fox in any interviews recently, where the body is moving continuously. That's called dyskinesia. This tends to happen more easily as the disease progresses. Now we call this something called the therapeutic window, fun name, but this is effectively like when you take any pill, the effect, I'm not sure if you can see the mouse now. Here it is. All right, so when you take a pill, the effect, there is some amount of the medication in your body, and that's going to go up, then it's going to go down. You take your next dose, it's going to go up again and come down. And then what we're seeing here, this is early in the disease, but again, don't look at those numbers. This is not 0, 4, these are not real numbers. But early in the disease, you take the pill, and then you don't touch too much side effects or too little side effects, okay? So you can think about like, I'm not taking enough medicine, that's on the lower side. I'm taking too much medicine, that's on the pink side. But as the disease progresses, those those walls, let's say, become closer. So it is easier for you to dip into like, the medicine is not as good for me. And then it keeps going, and then you can see that the distance between them is small. So you take a little bit of the medicine goes up, you get the too much side effects, like the body moves too much. Then after that, the dose drops again, and then you get that stiff. This one is a complex thing to show, but the idea here is that as the disease progresses, the medicine is still doing what it can do, but the benefit you're going to get from it becomes more complicated, becomes less consistent, and there are other symptoms that happen that make the benefit from it not as enjoyable. So effectively you're loose, but too loose, or you're suddenly very stiff. And then trying to balance between those and try to get the medicine dose to stay between those two lines becomes harder and harder, as you can see here. It's much easier when we have a big space, that's the window, and then that window is going to shrink over time. We call this the roller coaster ride. That's why we have those fun, happy people going down. So that's another name you might hear, is that as the disease progresses, the person is going to go into a roller coaster ride, which means they go too much, too little, too much, too little. You're going up and down rather than having a more steady state, okay? For each person, this might happen at different times of their disease. Some people might have this within the first few years. Others might take 15 years before these types of complications develop for them. So it's not the same for everybody. Now, there are ways to calculate your risk of developing those dyskinesias, like the extra movements. Your doctor can do that with you in the clinic, where we ask you to fill questionnaires sometimes when you go to the doctors. Most of the time you like, why I'm doing this, nobody reads them. But sometimes they can be helpful. One of them is, for example, calculating your risk of developing these types of complications. So some of that data can help us know where you are in that space. Any questions about all of these things?
I mean, so the disease process, you mentioned that it's basically a loss of the body's ability to, generate dopamine.
Mm-hmm.
You're replacing it with medication, but I mean, it's not just as simple as, the medication increase doesn't necessarily slow the disease progression.
Correct.
So why is that? In that, if it's just a dopamine problem, what's the kind of
because
behind it?
The dopamine problem is the end result.
Okay.
But the exact initial problem, that varies a lot from person to person. We don't have a way right now to measure or determine for each person what's the problem causing the death of the cells that produce dopamine in the brain.
Okay.
So that's the initial problem. What we're treating here is we're treating the end problem. Again, very similar to diabetes. The problem in diabetes is not, the result is that there's not enough insulin, but that could be for many reasons. Could be autoimmune, could be other complications. In Parkinson's disease, there are many possible causes, but right now that's still like in research, and we don't have a way to be like, person A, the problem is that they have a problem in their mitochondria and we need to rescue those. Problem B is autoimmune and we need to treat that. We don't have that.
Okay.
This is where the field is going, but it's not now. So what we treat is, we're not making enough dopamine. Let's give dopamine, but that's not going to make those cells come back. That's a good question.
Thank you.
All right, so other terms you might hear that we speak. So in terms of the fluctuations, we use these weird words sometimes. There's something called peak effect, which means that you take the medicine and then when it's working at its best, that's usually an hour after the dose is taken, and that reaches that peak. Like this is the best feeling. The best feeling might not be great sometimes. You get like, as we saw, like the peak could be too much, but that's the peak effect. There's something called predictable off, which means the effect of the medicine always wears off half an hour before the next dose. So that's called predictable. Unpredictable, as its name says, it's unpredictable. It could be 1 hour after the dose, 2 hours after the dose, it just stops working. There's something called sudden off. These are very disabling, and this is almost like turning the switch off. Suddenly there's no more dopamine in the system almost, and the body is very stiff, very slow, can be very painful, and it happens very quickly. And there's something called peak dose dyskinesia. It's again going back to that peak effect, but then at that peak dose, rather than having a good time, you're having a lot of those movements that are bothersome. And then something called end dose dyskinesia. Some people, as the medication is going away, so before the next dose, they start having those movements. And some people, they have those movements even with a very small amount all the time, and that's called brittle dyskinesia. So these are words that, as the disease progresses, you would hear us use, and this is when we start thinking of adjusting the medications and thinking of advanced therapies that we're going to discuss in a bit. So what do we do in these cases? We try to adjust the carbidopa-levodopa. We can adjust when you're taking it, how much you're taking each time, to try to minimize those side effects. We can add extender medications. These are medications that can stretch the effect of carbidopa-levodopa so it doesn't keep going up and down like this. We can use longer acting forms. So the other brands I mentioned, Ritari and Crexont, those are longer acting forms of carbidopa-levodopa. So they tend to have less of this roller coaster ride. Because it's a pill, you can have stomach problems, like difficulty with absorption, difficulty with movements, and so like what we call gastroparesis, sluggish stomach, and that can also cause some of those changes. So making sure that that's addressed. Also, if you're not taking your medicine on time, we need to be very strict. This is very difficult because let's say you're taking a medicine every 3 hours. It's very hard. Your life is now going to rotate around, when's my next pill? I'm going to carry my pills with me. Did I take them with me? Is my alarm on? Am I hearing my alarm? So it can be difficult. And then the other thing is treating other symptoms like sleep. If you're not sleeping well, your symptoms will be worse. Anxiety symptoms, mood symptoms also are going to make your symptoms worse. So it's not simply just treating your medication, but looking at other things. And that's to help decrease this roller coaster ride. But sometimes with the best of our efforts, we cannot. And the person is not having a good response to the treatments. And this is when we start thinking of advanced therapies. Now they're called advanced therapies. That doesn't mean a person has end stage or advanced Parkinson's disease, but they have complicated Parkinson's disease, you can think about it. So they have those fluctuations, which means the medicine is turning on, turning off, but not in a regular pattern. They cannot predict it very well. It's disrupting their life. They have a lot of the dyskinesias. They have tremor that's not getting better with the medication. Or simply they're tired of taking pills every 2 hours and they want something better. So in this case, this is where we consider those advanced therapies. And there are some tools to help us other than just asking you and speaking with you. One of them is called the 5-2-1 method, which means if you're taking more than 5 doses of carbidopa-levodopa a day, if you have 2 hours a day where the medicine isn't working that well, and 1 hour a day where you have dyskinesia that's bothersome, then in that case you need to speak with a neurologist about those advanced therapies. It's not foolproof. You might meet this 5-2-1. But then at the end, you go speak with the neurologist like, no, we can adjust the medicines. We don't need to go to the advanced therapies. But this will be like a good screening tool that you can think about. It's easy to remember, 5-2-1, 5 doses a day, 2 hours of off time, 1 hour of dyskinesia. And that should make you think about like, I can do better maybe with advanced therapies. So what are these advanced therapies? So there's something called DBS, Deep Brain Stimulation. Anybody can guess when the FDA approved DBS for Parkinson's disease?
10 years ago.
More. It's a guessing game.
20 years ago.
20 years ago, almost 20 years ago, yeah. It was in 2003. All right, so it's not a new treatment. It's been on the market as FDA approved for a long time. The first time it was used in the modern era, so I'm not speaking because there was some attempts of using it in the 1930s and 40s, but in the modern era, it was in 1989. That's the first time it was used, initially on monkey models and then in humans. But again, it's now a standard therapy. It's been used for a long time. There are 2 targets. It's called deep brain because it goes deep inside the brain. Many of you might have heard of pacemakers. It's the same technology effectively. But rather than having the wires inside the heart, the wires are going to be inside the brain. Now to go to the brain, you need to open the skull. It's a little bit hidden. So there will be a little bit of drilling to create a small hole to get that wire inside, and then that hole is closed after that. So deep brain stimulation is one of those techniques that a person can use. It does not cure Parkinson's disease. It's similar to the medications. It helps the symptoms, and it helps the symptoms when the medications are failing. So when you're having those fluctuations. When you're having the tremor that's not responding, when you're having the dyskinesia, this could be something that the DBS can help with. This shows like what it looks like. There is a battery. So far, it's a battery in the chest. There is a work of having the battery in the head, but so far the battery is in the chest. There is a wire under the skin. Nothing is outside. You can't see anything. Behind the ear, and then goes deep inside the brain. And then usually it's done on both sides. So you'll have two wires, and they go deep inside the brain into the middle, almost between your ears, almost into the space between your ears and the middle there. And then there is an electrical conductor there that will allow the battery to release that energy, and the energy from the battery is going to change how your nervous system responds and moves, and that can help decrease the stiffness, it can help decrease the slowness, it can help decrease tremors, it can decrease dyskinesias. But it's not a panacea, it doesn't fix everything. So if your problem is falling because you have poor balance, it's very unlikely that this is going to do anything. If you're having difficulty with speaking because your speech is garbled or slurred because of Parkinson's, it's not going to make it better. If you're having difficulty swallowing food, it's not going to make it better. Indeed, these are symptoms that can get worse with DBS. And then the cognitive symptoms not going to get better, sleep symptoms usually don't get better. So there are things that it can work for, and it is a great tool, but it's not everything. It doesn't fix everything, and this is why it requires some form of evaluation to see if you qualify. And there are, like everything, positives and negatives. The positives is that it can add around, on average, around 5 hours of this good initial honeymoon time. When you take the pill and the medicine works nice and there's no complication, it adds 5 hours of that on average in a day. That's huge, okay? From a person who might have been having like maybe 60% of their time not well controlled, you add 5 hours of that in a day, that's a significant gain. In terms of the side effects, it's a surgery, so you can have surgical complications like bleeding and infection. You can have device complications, like the device can break, the device can make you feel like zappy sensations. And then also you can have stimulation side effects, which is if we crank it up too much, other parts of the body are going to start activating, and then you might not like it. You might have double vision, or you might have spasm in the arm. Those are modifiable because they're related to the electrical stimulation, but those are some of the side effects. And this is something that will be discussed with a person in detail before they consider the surgery.
I have a question.
Yeah.
When do they usually consider the surgery specifically, besides with all the complications? Is there like an age that they would suggest not doing so?
So there's no cutoff for age, as you know, like the chronologic age is not the most important thing.
Mm-hmm.
Some people are 95, but they are like biologically 72.
Mm-hmm.
And some people are 60, but they have a lot of medical problems.
Mm-hmm.
So some centers, they cut it at 80, but not most centers do.
Mm-hmm.
But there's really no age limit.
Okay.
The main limit really is cognition. If a person has dementia or at high risk of developing dementia, then it becomes a very risky surgery, because then the surgery can precipitate worsening cognition. Outside of this, it's based mainly on the symptoms of the fluctuations, that roller coaster ride, the dyskinesias in this situation.
We were told that a lot of times they don't even do this until somebody is 80.
No, you don't want to wait to
Thank
be
you.
very old.
Thank you.
Because as we grow older, our body doesn't heal very well.
Thank you very much for
So if you qualify, like a person might be 80, but they don't qualify because they have some other problem, then yes, no. A person could be 60 and then they don't qualify, but could be a person who's 60 and they qualify. There's no minimal age and there's no maximum age, as long as there is a good assessment of risk benefit. I'm going to show you a video from Northwestern University about a person going to do DBS for another condition called essential tremor, but it's the same procedure, just to give you an idea what it looks like in the OR. So she's wearing something called a frame so that we know where we are in space. So that gives us like that space so that we know, otherwise we have no idea where we are in space. We need to create a frame. And this is the scariest part of the surgery, is getting that frame attached to a person's head.
Beginning of the procedure to help get a scan of the patient while she has a device on her head called a stereotactic frame that helps us both hold the patient steady on the operating table hold all of our equipment as we do the very delicate task of placing an electrode deep in the patient's brain, and help to provide us with
And you don't have to shave your head.
XYZ fashion to target those areas.
It's slightly lower risk of infection, but most people like to keep their hair.
Merge with the MRI, and we have all the data that we need to now target.
So this is like that frame allows us to have those images so that we can know where we are, and then the software will give us like a trajectory. So like go this way, and then you will make it to the target.
The Novocaine is all for the.
Are you awake? You're awake?
Yeah, you're awake because I was speaking when he was saying that the brain doesn't feel pain. The skin feels pain, but when you're in the brain itself, there's no pain. The brain has no sensation. This is the hole I was speaking about. It's very small. It's the size of a dime. And then we do testing. So each part of our brain, of our body, has an image inside our brain, so we can test it. Are we in the hand area? Are we in the foot area? And then there are areas that we want to be in.
We'll be able to listen to the brain activity.
It's electricity, so you can listen to that.
I'll be moving the patient
For me, it's fascinating. It's very cool.
Here if they change their pattern in response to the pain. Once we've determined.
And then you can hear, you move this and you can hear the brain signal changing. And be like, I'm in the hand area, that's cool, because we want to be in the hand area usually.
Satisfied with everything, she will be given more intravenous sedation to go back to sleep, and we'll begin the process of anchoring the electrode down and burying it under the skin, sewing the electrode up. Typically, patients after this procedure spend 1 night in the hospital in a regular room without a need for an ICU stay and go home the next day.
Wow.
Awesome.
Tremor is very satisfying because you see the benefit very quickly. The other symptoms like stiffness, slowness, you won't see that much of a dramatic improvement. Tremor is very dramatic because it's there, and then you do the surgery, immediately it goes away. The other symptoms are not as dramatic, but they still get better. So this is, again, a technology, that's not new, okay? It's been there for a while. The new thing about it is trying to make it smarter, trying to make it adaptive to your situation, to your needs. Because a person with Parkinson's, their symptoms change through the day, change with the medications. The device that we have right now gives the same stimulation all the time, whether you need it or not. Okay, so it just does it all the time. And that can cause problems in terms of draining the battery, but also makes higher risk of some side effects like cognitive side effects. So the new developments that happened right now is to use adaptive DBS. So a DBS that listens to your brain and uses the signal to try to adjust the response. It's not perfect, and there's a lot of work that needs to be done, but this is a good step forward. And there are 3 ways to do this, and you can see them in this graph. And you don't need to memorize them, but one of them is the LFP. This one is available on the market right now. There's ECOG, which means they put strips. It's very futuristic, this one. They put strips inside your brain, on the top of your brain, and then it's almost like it's more like very cyborgish, okay? And then you will have those strips on the brain that are in different portions of the brain. And the other one is wearables, like your Apple Watch, your phone, any device that feeds into the DBS again. But the only one right now that is FDA approved is using LFPs. So LFPs are signals from inside your brain with the same wire that's already in. So the same wire already inside your brain can now detect or sense or listen to your brain and see what signals are happening. And there's one signal, it doesn't apply for everybody, but there's one signal that we can use that tells us that the symptoms of Parkinson's are not well controlled. That's called beta band or beta abnormality. And then that's the signal that the device is going to listen to or see. And then once it sees that, then it can adjust its settings, okay? And then that way, if your medications are controlling your symptoms well, that signal is not going to be there and your DBS might turn off or go very low settings. And then once this abnormal signal comes back, then your DBS ramps up and then gives you the signal when you need it. So it's smarter and much more on demand. So this was approved very recently, February 24, 2025. It's not yet disseminated in the market, but will be very soon. It's a software update. It's not a big. So if a person has DBS, they will use it very soon. So you will identify that signal, and then you will determine. There are 2 ways of doing this. There is a way called single threshold and another way dual threshold. So single threshold means that this, let's say this is the signal, the blue line is the signal. You want that blue line to be under that line over here. So as long as the blue line is under that line over here, the DBS is going to be off. The DBS line is the red line. And you can see here, every time it crosses over, the DBS ramps up, gives you more of that stimulation. Once it dips over, down, it stops again. It goes up again, and then it stops and goes down. This one is like on, off, that's it. That's on, off, on, off. If you want it to be a bit smarter, you can do 2 thresholds if you want to keep between 2 things. So you will have like a lower threshold, which is this one, and a higher threshold, and then the system then responds. It wants you to stay, because we want you to stay here. So every time it goes above, it does this, it increases, but then if it dips too much, then it drops again and then stops it from working. So it's like a little bit smarter 2 ways rather than just on off. All right, so the advantage of this over the conventional DBS is that it increases a little bit the on time. So that good time, the honeymoon time, already spoke with DBS, is on average extra 5 hours. So it adds another hour to that good time. So it's not too shabby. And then it seems to be clinically significant, which means the person who gets that procedure says that this is better. I like it more. It helps my life a little bit more. The energy demands are a little bit less, not much complications, and most people who tried that wanted to be on it. So that's what we know so far. Again, it's very new, approved, so we will learn much more as we use it more. But that's DBS. The other techniques that are, okay, sorry.
What are the rates of success?
For DBS?
For DBS.
So the DBS, the rates of success, if you take everybody, is around 70%. But the problems where people fail are either because they weren't selected correctly, which means they don't have symptoms DBS works on, the device broke, or they don't have Parkinson's. Because there are conditions that look like Parkinson's, but they're not, like something called multiple system atrophy. If you DBS in this situation, the person gets worse. So it's not like the DBS isn't working, it's just the process to get the DBS failed somewhere along the way. And it happens, where like a person gets DBS, they worsen, they don't get better. So it's not 100% success for sure. So the other technique is infusion therapies. So this is a pump. So you're giving the medication in a pump. So rather than taking it by mouth, you're infusing it. And the older one that's available in the US was a pump into the stomach or the intestine. So you have to have a tube through your skin into your intestines, it's almost like a feeding tube. And then connect it to a pump, and then the levodopa or the carbidopa-levodopa gets in, and then effectively bypasses the stomach. You don't have to take pills because it's being pushed on all the time. The newer ones that were approved more recently are a subcutaneous pump. So rather than having a tube in the stomach, now you have a small needle going into the skin, similar to an insulin pump. I keep going back to diabetes because a lot of similarities there. So it will be in the skin. There's no need for surgery. You just apply it yourself. And it's a small needle in the skin and you move it around. And the other one is another substance similar to the levodopa called apomorphine. It's not related to morphine. It is, but it's not. It doesn't work the same way. But this one is something called dopamine agonist. So it mimics dopamine in the brain. It doesn't make dopamine in the brain. It just mimics it. So it can do the same function that dopamine does. So the hope from these treatments is, before we spoke about this, like where there's that roller coaster ride, is to make it that pinkish one, where the fluctuations, the ups and downs are much smaller, and then you can stay in that nice middle ground. So you don't hit any of those thresholds, you don't hit any of those areas of problems. So the 2 ones that are approved recently in the US is Vyalev, that's subcutaneous carbidopa-levodopa, and the other one is Onapgo, and that was approved in February this year. Okay, this Onapgo has been in Europe for 10, maybe 12 years approved, but hasn't been approved in the US for very weird reasons. Okay, but so it's not a new treatment. We know a lot about it. It's very safe. But the other one is Vyalev, is the newer one with the carbidopa-levodopa. So this is a little bit of comparison between them. So Vyalev, which is the carbidopa-levodopa subcutaneous one, effectively, the goal is for you not to take any more carbidopa-levodopa by mouth. So you just have this, you don't take anything extra. It increases your good on time, that when the medication is working, the honeymoon on, by around 1.7 hours. Right? So not as much as DBS, but still a reasonable amount. And the side effects usually are like when you have a needle in your skin, you can get a rash, you can get an infection there. Some people have hallucinations, which is a possible side effect, and dyskinesias. Sometimes the dose is not very well adjusted. For the ONAPGO, it's very similar. You gain also 1.7 hours of good time, and the side effects are very similar. But in this case, you don't stop taking the carbidopa-levodopa. This will be in addition to your pills. You might not need to take them as much or as frequently, but it won't replace the therapy. And this is what they look like. These are these devices. You will strap them to yourself. You can have like a side strap. You can have a vest. You can have a waistband that attaches the device. You put a needle in your skin. There's a device that comes with it. You just push a button and then puts the needle in, and then it sticks there, and you connect it to this pump. These are the pumps. This is the size of the pump for the carbidopa-levodopa pump, and this is the size of the pump for the apomorphine pump. They're not very heavy. The carbidopa-levodopa pump is the same weight as a large apple. And then the apomorphine one is small to medium onion. This size onion. Okay. So a bit lighter. This one is rechargeable. So you get a battery that you have to recharge every day, but they give you multiple batteries, so you just flip them each day. And this one here is a regular lithium battery that you need to change after 90 infusions, so it stays on for a long time. So those are the main things I want to discuss with you today. So there are these kinds of situations that we consider these options. So a person wakes up feeling very off. Many people with Parkinson's wake up and they cannot move. They need to take that first pill. And then let's say we did some trial, we tried different things, and then but the medication is not working. This is a person where taking that subcutaneous carbidopa-levodopa infusion can be great, because then they're getting that medication 24/7. There's no block, there's no stop, so that morning time generally tends to be better. If they're having a lot of freezing, what we call off freezing, which means when the medication goes off, they freeze and they have fluctuations, either one of the infusion treatments is a good option. If they have a lot of dyskinesia, motor fluctuations, DBS generally is better. If there is a lot of those ups and downs with dyskinesia, DBS is better than the infusions. But again, there's no rule. It just depends on the patient, their situation, their other problems, like do they have heart disease, do they have other things going on, and that will help us make the decision with you. So the main thing to remember is that Parkinson's is a progressive disease. The things that progress are motor and non-motor. Physical therapy and exercise are central throughout the course of the disease. Advanced therapies can be a consideration for some people, so that's the DBS and the infusions, but the care is not specific, it's not the same for every person. Each person is different, the care is individualized. I like that sun and the planets, so make sure that if you have Parkinson's to be the sun, and there are planets surrounding you to help with your care. And that's it. Any questions, comments?
I got a question. As physical therapists, our treatment tool is exercise, and you mentioned it a couple of times that it helps, if I understand correctly, helps extend it 3 or 5 years. I guess as physical therapists, we want to be as efficient with our time as possible. Is there a difference between cardiovascular exercise versus weight training? If we had 40 minutes to work with, what percentage of which would you suggest?
Yeah, I'm not a physical therapist, but I'm telling you what I know. But the most of the data has been done on cardiovascular exercise rather than weights. So in terms of, there's a bias in the research. So a lot of cycling, a lot of running, a lot of dancing, a lot of things like that. So a lot of it is cardiovascular in terms of that evidence, and especially if we're looking at evidence of slowing down disease progression. Cardiovascular has more of that evidence, whereas weight training doesn't have as much of that evidence. But if the goal is, for example, not falling, it's different a little bit. In that case, you want to work more on like gait mechanics. You want to work on like core muscle strength. You want to work on like that dual tasking, where like cognitive stressing, and again, PT in the room can save me here, and then trying to decrease so effectively trying to combine different things to try to create a program that works best for a patient. Now, the programs that have approval, one of them is, let's say, the LSVT big program, and that combines multiple things, combines some cardio components, but also range of motion, balance, and then core strengthening exercises together. Was I too far?
No, that was good.
Okay.
Where do they do the DBS surgery around here?
So we do it at UMass. They do it in all the Boston big programs, and they do it also at Bay State. And these are the ones I know in Massachusetts. Yeah.
You said cycling is good
Cycling is very good, yeah.
in addition to PT.
In addition to PT. The more active you are, the better you're going to be. And you don't need to be like, I'm going to like cycle for an hour. You don't need to do like a Peloton exercise all the time sitting there. But you can do 10 minutes here, 10 minutes there. It's better than, for sure, than not doing any exercise.
Stationary bike is.
Yep. There is a good amount of data of cycling of Parkinson's disease, and
Don't
that's on stationary
fall
bikes.
over.
And then even if you have back problems, you can get those recumbent bikes. Unfortunately,
Yeah,
they're
right.
expensive, but those are options too.
Okay, good.
Now, is there like a lifespan on the DBS thing? So say someone's in their 50s and gets it, if they're making it until they're in their 80s, is it still gonna be just as effective?
It will be as effective, but then there's a component related to disease progression. So DBS will continue, and we have data for 20 years now on DBS, and then DBS will continue to help the symptoms it was supposed to help with. So it will continue to help with stiffness, it will continue to help with slowness, it will continue to help with dyskinesia, it will continue to help with tremor, but disease progresses and then other symptoms come in. So a person might start having cognitive problems, it's not going to help us. And then the person, if they're having dementia, they're not going to care too much if their hand is shaking. The other thing would be, for example, urine control problems. If a person is having urine control problems, that's going to become a bigger problem than how slow they are. So it feels that the benefit is going away, but then if you look like objectively at the benefit is still there. What we see is that the younger you are with Parkinson's, the slower the disease is going to progress, and that's in general because of more body reserve, like for anything else, right? Like when we're younger, our body is healthier in general, so it can compensate a little bit better. So that's also, if you have Parkinson's and you got the DBS, you had it early and you got the DBS early, you most likely will live with Parkinson's longer with the DBS on.
And do you supplement with the medications with the DBS to help with those other non-organs?
Yeah, it's a good question. So there are two targets. There's the SDN and the GPI. Both of them you need to stay on medicines. You will not stop medicines, but the SDN can make you, allows you to decrease the amount of the medicine you can take up to 50%. That could be a good thing for people. That could be a bad thing for other people. So that for people who are like, I hate taking pills every 2 hours, then the SDN could be a better target because it allows them most likely to decrease how much they're taking, but not zero. Everybody will have to take something.
Not to dwell on cycling, but why? Why would that?
We don't know. It's just like we know it works. It's not like it wasn't done in a very scientific fashion, right? Scientific fashion, like you have a hypothesis, like it does this, then we test it. So it was like, oh, let's do it. Oh, these people who cycle do better than people who don't. And then now we're looking at, and it's not, again, not only cycling, but cycling has data on it. But there are hypotheses. Some of them are related to, like in terms of blood flow to the brain. Others are related to the cascades, like how the proteins in the brain are going to respond to exercise. Others are related to stimulation, just the fact that you're moving is going to stimulate your brain and activate those pathways that are not very active, but nobody knows for sure.
Well,
Is there a genetic component to Parkinson's?
For some people, the current amount of people who do genetic testing with positive genes are around this is rough estimate, around 10%. So it's not a high number, but there is. And then if you have two parents with Parkinson's disease, then the chance you will have it is 20% higher than the general population.
It seems some families have,
Correct.
through generations, have a.
Yeah, and that those families will be good for them to get tested. If there are if you see that inheritance pattern, then in that case doing genetic testing can be helpful. But it's not 100% thing anyways.
What's the cutting edge research right now?
Depends. So there is a lot.
Everything depends.
Depends on what you're cutting it for. As I said, Parkinson's is a big thing, right? Like there's so many things. The most exciting is trying to work more on trying to determine for each person what kind of Parkinson's they have, so that develop treatments on the root cause rather than just the symptoms. That's very exciting.
How many types are there?
We don't know, it's a lot. We think there's a lot. And that's why there's a lot of, some people call it Parkinson's diseases rather than disease. It's like how you think of cancer. It's called cancer, but it's very different, right? Each person is different, each cancer is different. So that's very exciting because that's going to change the game. If that becomes positive, even for 5% of the people, that's going to be the first time we can do something to stop the disease from progressing. So that's exciting, I think. The other thing is developing more. I am a person who likes gadgets and tools, so DBS and then connecting things and then having more smarter ways of treating symptoms is also good. And then also addressing some neglected symptoms in Parkinson's: pain, sleep, urine symptoms. We don't have a lot of great treatments for them right now, so that's also exciting, I would say.
does it have to progress?
Usually it does. There is a kind that's really not Parkinson's, and not everybody agrees it exists. Something called benign tremulous Parkinsonism, where the person presents with tremor that looks like the tremor I showed you, but this person lives with this condition for 30 years and barely have any progression. But it's not really Parkinson's. But if it is regular Parkinson's, it will progress. But the rate can be very different. Some people have a faster progression, and some people can live 20, 30 years with it.
I had a good friend in college. She developed Parkinson's at about age 45, and it became very bad very quickly.
Yeah.
She did have DBS, I think, 10 or 15 years ago, which is why I guessed that. She had to go back and have it done again, so I'm guessing a new device.
A new device or a problem with the wires.
Yeah.
Like any wire, it can break, it can fray. The battery might not lose connection. Sometimes also the wire can move. If you had a car accident, the yanking can move it a little bit.
But she's still progressing, and
Yeah.
now she's developing dementia.
Yeah.
They said it's helped some with her symptoms of the stiffness and the tremor, but not enough to make a big difference in her life.
Correct.
So is that unusual?
It's not unusual, and that's again because of the weight the symptoms have. As the disease progresses and you have these other symptoms that DBS doesn't do anything about, you need to have a frank discussion with the person about what is important to you. If I fix your tremor, is that going to make your life better?
Yeah.
Is it really, or is just not really? And then making sure that that's true. If that's true, yes, it's still going to be a good idea. But if it is nah, I'm not bothered by it too much, it's just a nuisance, but I'm bothered by my balance, then DBS might not be a good option.
Yeah, she's got the whole battery of symptoms.
Yeah. All right. Thank you.
Thank you.